this semester. So postpartum newborn, and hopefully it'll be a lot of review since most of you have gone to clinical. I know some of you have had COVID exposure and all those kinds of things, but we're getting through it, right? The best we can. And so we'll just trudge on. Okay, well, there's one student to come, but hopefully she'll be able to get in on it. So let me share my screen and show you, and I will record it. Somebody asked if I would record it. And let me see here, find my, I'm not seeing it. Okay. Oh, it's not showing up. Okay, there it is.
Excuse the word except for I'm gonna go with.
All right, that's not working. Hang on just a second. Let me just get out of all these other ones. Maybe that'll help. Okay. All right, share my screen. Okay, so let's see. Let me start recording. All right, let me stop sharing, start recording. I guess I can't do that with sharing. Now I will share. Okay, so as you can see, there's quite a bit of reading. So please get started on the reading. I put up the first set of PowerPoints, and I did not teach last spring when we had OB. So I'm just going through and making sure the notes are clear and all that. So I will be putting the PowerPoints up as I go through and tweak them, but please get started on the reading because there is quite a bit. And so we'll get started on the PowerPoints. Okay. Sorry, working out the kinks. Trying to figure out how I just have myself up here. Be able to figure it out. Okay, participants. Picture, that. More. Sorry, I should have figured this out beforehand. Okay. Let me pause the recording for a second. Does anyone know how I just show myself by any chance? Are you Zoom?
We only see you. Well, I do.
Okay. Well, they don't want us to record with everybody else being seen. So there's supposed to be a way that I just show myself.
You should be able to pin yourself
Oh,
as the main speaker.
Okay. Now, where do I find that? Just edit picture. Not finding. Who said pin myself? Does anyone know where I pin myself?
It's Maya. So
Maya.
I think if you escape and get us out of this little window, you should be able to see 3 dots at the right corner, I think, and you should be able to pin yourself as the speaker.
Okay. So like minimize, you guys?
Sure, try that.
Okay. Oh, wait a minute. Oh, you cannot minimize Zoom when you're recording. Let me just stop the recording since we haven't really done anything. Okay. And then yes. Yes. So if I hit speaker view, then you're just going to see me or no?
Okay, I got it. So if you click out of speaker view and go to gallery and hover over yourself, you should see the 3 dots in the right-hand corner.
Yes.
If you click on that and hit pin, you'll only see yourself.
Thank you very, very much. I appreciate your help. I didn't think it would be this difficult for me to figure out. Thanks, Maya. I appreciate it. Okay. There we go. Perfect. Okay. All right. Now I will share my screen. Wait a minute. Let me start the recording. We'll get all these technical glitches out of the way here. All right, record. All righty. Now I'll share my screen. And yay. All right, there we go. Perfect. Okay. Let me get this the way I want it. There we go. Perfect. All righty. Any questions before we get started? Everybody good? All right. Okay. So we'll begin by talking about involution. Oops, somebody needs to mute their mic. And involution is the return of the uterus to the non-pregnant state. Postpartumly, we do want that to occur. And it starts happening immediately after delivery of the placenta. The fundus descends or goes down 1 to 2 centimeters every 24 hours. So if you've been to OB and you remember my postpartum assessment instruction video demonstration, we use our fingers. So it's like 1 to 2 finger breaths below the umbilicus, below the belly button. And you'll see right here, we start at the belly button, Then 1 below would be U over 1. 2 below would be U over 2. And if it was above the umbilicus, it would be 1 over U. Does everybody understand that concept? Because 1 finger breadth, 1 centimeter above the umbilicus or the belly button. So it's important to remember that it descends 1 to 2 centimeters every 24 hours. And 6 to 12 hours after birth, the fundus, which is the top part of the uterus, should be level with the umbilicus. Okay, so it should be right at the belly button. How we document that is U over U. Okay, can everybody mute their mic, please? Thank you. So we're checking the fundus. We want to make sure that it's nice and firm, right, after delivery, because
Ms. Chandler,
yes.
can you go back? Somebody's mic wasn't muted and I didn't hear what you said in regards to where the...
Okay, sure. All righty. So when we look at, or when we're checking the fundus to make sure it's nice and firm, and we call the return of the uterus down to the non-pregnant state, back down into the pelvis where it belongs, involution. So we want to see that occur. So how that happens is it goes down below the belly button, umbilicus, 1 to 2 centimeters every 24 hours, or how we measure that when we're doing the fundal assessment is it's 1 to 2 finger breaths below the umbilicus each 24 hours. So right at 6 to 12 hours postpartum after delivery, we're going to find the top of the uterus, which is the fundus, at the umbilicus. And we would say that is U/U, okay? Then the next day, we want to see it at least 1 finger breadth below. So that would be U/1, okay? And sometimes it may be a little bit higher than that. We don't get really concerned about that. You know, if it's just 1 centimeter or 1 finger breadth above the umbilicus, we're not really concerned. But what we may have the patient do is get up and go to the bathroom. We'll talk more about that, urinate, because the full bladder can definitely push up the uterus, and we don't want that bladder to be full, right? We want that bladder to be empty so that uterus can clamp down really well on that fresh area of where the placenta detached, so it will contract well over those blood vessels. But anyway, so if it was 1 above the umbilicus, it would be 1/U, okay, or 2/U, okay. So that's how we want it to descend. And I said that 6 to 12 hours after birth, it should be at the umbilicus. So if we feel a boggy uterus, now a boggy uterus feels very soft and spongy rather than nice and firm and well contracted. What we would want to do is massage that fundus, okay? And you want to be very gentle when you massage it. You're just taking your hand. Of course, you're supporting the uterus at the symphysis pubis, and you're just massaging it to get it to firm up. And it's kind of cool to feel that happen when you're assessing moms. But definitely we want to get on that and massage that fundus if it's boggy. Because what happens, blood collects there at the placental site, blood clots form, and of course this interrupts the contractions. So we want to make sure that that uterus clamps down on that area so we don't have any bleeding issues. So we definitely want to massage a boggy fundus if we find that. If the fundus is higher, as I said, than expected, and if it's not midline, so it should be right in the middle, you know, right below the umbilicus, you know, and our belly button is in the middle of our stomach. So it should be right there. If it deviates off to the right, then what we suspect, if it's you know, it's kind of hanging to the right and it's up a little further than it should be, that is an indication that the bladder is full. So we would want moms to get up and urinate and then reassess their fundus, because that could be the problem. What happens postpartumly is sometimes moms aren't fully aware that they need to urinate. So we want to remind them, even if they don't feel the urge to urinate, that they need to do that every 2 to 4 hours. So if it's been 2 hours, no longer than 4 hours, they need to get up, they need to go to the bathroom, because that can definitely interfere with that process of clamping down on that new area where the placenta was embedded. Okay. And this, the feeling, okay, somebody needs to mute that just got on. The feeling of not feeling that bladder is also related to the stretching of the ligaments, the ligaments around the uterus too. So there's a lot that goes on with that bladder. We'll talk more about that in just a minute. So what we call when the uterus is not going down, not descending as it should, is subinvolution. And we want to further investigate if we find that uterus is not going down as it should. And the most common cause of that is if there's retained placental fragments. So I'm sure Ms. Walker talked about that it's very important that you look at that placenta when it comes out to make sure there's no pieces missing, because they could still be up in the uterus, and that could interfere with that process of that uterus clamping down on that area because of that fragment being in there. So we want to get on that. And if it's not picked up, also it could lead to infection and could lead to a late postpartum hemorrhage. So I'm going to talk in just a little bit about what are our early postpartum hemorrhage risk and what and causes, and what are our late postpartum hemorrhage causes risk. Okay. So just to remember the importance of that uterus clamping down on that area, compressing those blood vessels for the uterus. We want that uterus to remain firm. So what you're going to see right after delivery is those of you who get the opportunity to go to labor and delivery. I know some of you guys have missed that, unfortunately, because of COVID, but they'll go ahead and run in Pitocin afterwards. And as you've learned, we use Pitocin to induce labor, but we also use it postpartumly to get that uterus to really clamp down, because we don't want anyone to have bleeding problems. And it's really important right after delivery that we get that uterus clamped right down. So they will give Pitocin IV at a higher rate than they did if the mom was induced. And it'll go about 125 milliliters an hour. Whoops, so sorry. My husband doesn't know my schedule. So they'll run in Pitocin, and that helps that process of clamping down that uterus. It can be given IM, but typically all moms have IV Pitocin, or they have an IV running during labor just in case it's needed. And so they'll run in that Pitocin. And this definitely compresses that uterus right down on that placental site, which is like a wound that needs to be, clamped down on. We put pressure on wounds, so the uterus is putting pressure on that new site that the placenta used to be at. Okay. All right. So what we're going to see is with the healing process, that placental site will become an irregular nodule and an elevated area after the expulsion of the placenta. And it takes about 6 weeks for the placental site to totally heal. So the uterine lining has 2 parts. It has this outer spongy layer, and that is what turns into the lochia, which is the bleeding that occurs postpartumly. We call it lochia. And the inner layer forms the new endometrium. So the outer layer becomes necrotic and is sloughed off, and this is what the lochia is. And this process takes about 3 weeks. The first bleeding or discharge of lochia we will see is called rubra. And it's a darker red. It's not a bright red like active bleeding. It's a little bit darker, and it has a fleshy smell to it. It should never be a foul smell, though. So that lasts about 2 to 3 days. So usually the amount of time that moms are in the hospital this is what we're going to see their lochia color be, is rubra. Then after the 3rd day, it changes to serosa, which is the pinkish. So it's a lighter pinkish drainage discharge lochia that we see. And that goes on for about from the 3rd day to about 10 days. Sometimes with our C-sections, because the doctors are manually taking out that placenta, they tend to get into the serosa a little bit quicker, and it's individualized. Sometimes we do see it while the patients are in the hospital, but typically if we're going to see it, it may be in our C-section patients while they're there. So after the 10th day, the lochia becomes a creamy yellowish color, and that is called alba. And at no time should it have an odor to it, okay? We always want to ask our moms when we're doing their assessment if they're passing any clots and what size they are. So we don't get concerned about small clots that they're passing, but anything the size of a golf ball or larger, we would want to take a look at and, maybe have intervention for that. So if moms say, yeah, I've been passing a few little clots, well, if it happens again, just don't flush the toilet, so we can take a look at it and make sure that it's not a concern, okay? So we always want to know if they're passing any clots and how big they are. Don't want them any bigger than a golf ball size, okay? And once the lochia stops, that means the cervix has closed. So that's a good sign for moms when they get home, that if they're, once their bleeding lochia discharge stops, that means that the cervix has closed, which is good because then the uterus is safe from infection at that point. If moms, and we always want to teach moms about this, have a persistent rubra color of lochia, or it progresses to serosa and maybe even alba, but then goes back to rubra, this can be a concern, okay? It can indicate subinvolution or late postpartum hemorrhage, okay? Because subinvolution can lead to late postpartum hemorrhage. So it's definitely something we want to warn our moms about, that if this occurs, then they need to contact their doctor and go in and be checked for that. And they can do an ultrasound and see. Again, the subinvolution is usually caused by placental fragments. So they can see that on the ultrasound, and that patient is typically, which I'm getting kind of ahead of my content, but typically they have to go in, they have to have a D&C, so dilate the cervix, curettage, scrape out that area, and then they'll be back to normal. Sometimes they just order medications like oxytocin, but it's called Methergin, which is also an oxytoxic, and that can help with that, so they may opt to try that first if this occurs. But back to what happens initially, well, getting back to our parts, the cervix. So the cervix, again, will be closed once the bleeding stops. And forever after that, once a woman delivers a baby, the shape of the cervix does change. So it becomes a slit as opposed to a donut hole area on the cervix. Okay. So immediately after birth, there could be some bruising of that cervix or lacerations. So we'll talk more about what to look for if we suspect a laceration. I won't go into that in detail at the moment. But it does become a transverse slit instead of the circle that it was before they delivered a baby. Okay, sorry. Okay, all righty. Getting interrupted. Excuse me. Okay. Okay. All righty. Let me know if you have any questions about that. Anything. You can stop me. Oops, let me go back. Missed one. Okay. A little bit about the vagina and the perineum after delivery. Of course, that area's, gone through a lot to get that baby out. So, definitely it's normal to see edema at the perineal area. Around 3 weeks, the size of the vagina decreases to much smaller state, and the vagina returns to normal about 6 to 8 weeks after childbirth. There does dryness can occur just because of the decrease in estrogen, especially with our moms that are breastfeeding. And it takes a while for that dryness to go away, even in our moms who are formula feeding. So we want to let them know that they can use a water-soluble lubricant like KY jelly for intercourse until, that dryness resolves. But that's due to the low estrogen level, and especially in our lactating women. Episiotomies, we always want to assess that. We have the moms roll over. If they delivered vaginally and just check that area, make sure that, it's going to be, a little edematous. It's going to be a little red, but there should not be a lot of edema, a lot of redness. So we're checking for RETA, redness, edema, ecchymosis, drainage, and approximation. So it should be well approximated. And, if there's edema and there's ecchymosis, we definitely want to put ice, but I will go into that more in just a little bit also. Okay. But we want to get ice on that really quickly. So that area heals pretty well in about 2 to 3 weeks, but for it to completely heal, it can take, depending on the degree of the episiotomy, if they had to have an episiotomy, or a laceration. If they ended up having a laceration, it could take 4 to 6 months. It could just be tender for a while for that area to totally heal. When we look at ovulation, it varies. It can be be delayed in our lactating women as opposed to our non-lactating women. In other words, our breastfeeding moms as opposed to our non-breastfeeding moms. But typically in our non-breastfeeding moms, it's going to resume in about 2 to 2.5 months, or 70 to 75 days. And lactating moms, typically about 3 months. But there's kind of a myth about breastfeeding as a good form of birth control, which is not an accurate or a reliable form of birth control. So we want to let our moms know, hey, you even though you're breastfeeding, you may not have your period, but you could still ovulate. So definitely use some form of birth control. But even if, they're not using birth control, they should start ovulating about 3 months. But again, we want to let them know, not reliable, everybody's individual. And, you want to make sure that you're using some sort of birth control before that point. Okay. Striae or stretch marks remain. And, depending on your skin type, some people have more stretch marks than others. But the good news is that they do fade and they do become lighter. So that's the good news. Right after delivery, when we're looking at the abdomen, some women are very discouraged because, their stomach is still kind of protruding a little bit. That's normal. It just takes time, can be fluid. That area muscles have been stretched and it just takes a while to get back. But they may still look pregnant. So we'll just say that's normal. Don't worry about that. That's going to resolve. I'm sorry. Mentioning one other thing about the stretch marks. It's due to the rupture of the elastic fibers in the skin. In Caucasian women, like I said, it'll fade in darker skin moms and lighter skin moms. But in Caucasian women, it will fade to a silver to a white. They typically are kind of bright pink in the beginning, but they will fade, which is good news. Darker skin moms, they remain dark, but they do also fade. So another finding you might find on the abdomen when you're doing your assessment is diastasis recti abdominis. So what that is, as you can see on this slide, is the separation of the rectus abdominis muscle here. Let me get my little pointer, okay? And that is normal, can happen. And usually, typically, it responds well to exercise. So if moms can, of course, we don't want moms exercising too vigorously, initially, but they can do some little, lifts off of their head off the pillow, start doing a little bit of the abdominal strengthening exercises, which we can give out to them when they are discharged with discharge instructions. But this can occur and typically it resolves on its own. So we can let moms know that. Because tone usually goes back to your previous tone that you had before. Okay. All right, so when we're looking at the breast, the first milk or nourishment for the baby is called colostrum. And colostrum is a wonderful thing. It has antibodies in it for baby to fight off infections. It is easily digested for the baby. It helps the baby pass the meconium stool. Nature is best always. And even if moms can just feed their babies the colostrum, they're doing their babies a great favor. But, so that's the initial fluid in the breast. There's not a lot of it. And some moms kind of worry about, okay, my baby's not getting enough. I'm afraid my baby's not getting enough. There's not much. But that's all the baby needs. When the baby's born, their stomach is very small, very small. But we tend to stretch it when we start feeding these babies. So, in the first few days, colostrum is all those babies need, and most babies are satisfied with that. The true milk will usually come in definitely by the third day. Second to third day, I would say typically what I've seen is it comes in about the third day, 72 hours. And at that point, the breast becomes full and a little bit tender, and moms just need to be breastfeeding, because it's like when your milk first comes in, it's like overproduced for some reason. And so I remember just waking up and feeling like 2 boulders were sitting on my chest. But the body will adapt to what the baby needs, and you'll have supply and demand. As much as the baby nurses, the supply will be there. So of course we want our moms in the initial days to breastfeed frequently. Now they don't say every 2 to 3 hours, as Miss I can't think of Kimber's last name. Miss Kimber, I can't think of her last name. Shive, I think. Yeah, Shive. as she said, hospitals have become what they call baby friendly. So, we really want to encourage breastfeeding. But, we're not going to force any mom to breastfeed that doesn't want to. There's some moms that are just not going to, don't feel comfortable with it, and that's okay. But of course, we want to be very encouraging. We want to help moms that, want to breastfeed, help them to not get discouraged, because it's not always easy for some of these moms. You would think it's the natural thing to do, but there can be some issues, and we'll talk more about that. But definitely it is best for them to breastfeed. So these hospitals won't give pacifiers, and like I said, we'll do everything we can to not encourage mom, be cheerleaders for mom when she's getting discouraged that it's not going well. So even in our non-breastfeeding moms, they can develop engorgement, which is hardening of the breast. It's when the milk comes in, overproducing. And it can be painful, warm. Their breast can be warm and tight. When we're assessing the breast, we're feeling for, and typically this doesn't happen until they go home. So when we're assessing moms, their breasts are soft, or, if we catch them the second day with it coming in, then it may feel like they're filling. So they might feel a little bit firmer. But when the true milk actually comes in, usually they're very firm, and they can be very hard and painful and warm, and appear very taut and shiny. And the best relief for that is for moms to breastfeed baby. So we're monitoring for that. We'll talk more about treatment for that in a little bit, but what we're checking for with our breastfeeding moms is making sure that their nipples look all right, because that's probably the biggest problem with breastfeeding, is not getting that baby latched appropriately. So they get that deep latch on the nipple. If they're just sucking on the end of mom's nipple, mom's going to end up with blisters, mom's going to end up with cracking, and this could lead to an infection, which we'll talk about later, in the breast. So, and then, if they get those blisters and cracking and soreness at the nipple, then, it's very uncomfortable for them to breastfeed, and it's hard for them to heal because that baby's, continually sucking on the nipples, of course. So we want to try to avoid this from happening. So we want to make sure, and we've got the wonderful lactation consultants in the hospital, and they get in and, are very good at working with these moms. Of course, the nurses also are trained to work with these moms to make sure we're not having problems initially that can, be lasting long, for a while. Because once those blisters and cracking occur, it is hard for them to heal up. So we definitely want to be monitoring for them. We want to get lactation consultant in there to help them if it looks like they're not latching, the baby's not latching good on mom. So what we want to instruct our moms, which I went over in the assessment also, is any moms that aren't breastfeeding, and that's perfectly fine. Our formulas, our babies do just fine on formula. So we never want to make them feel guilty or, bad about feeding with formula. That is their choice, and they know what's going to work for them. So, but so we can avoid the engorgement. We want our non-breastfeeding moms to get a tight bra on, and sports bras are a wonderful way of containing those breasts if they don't have a tight bra. So I always recommend a sports bra. And then we want to instruct our moms to have no stimulation of the breast, just leave them be. Even when we're doing our assessments, if they're not breastfeeding, they've never not breastfed, we may take a peek and just make sure, there's nothing, alarming that we see. but we're not going to palpate. We're not even going to palpate their breasts because even that can be stimulating, the milk to come in. So we don't want to do that. So we just instruct them to get that tight bra or their sports bra on, no stimulation of the breast. Also back to the shower, no warm, water, hitting their chest, which can also stimulate the milk to come in. So, hopefully we can avoid engorgement with that, because we don't give medications. We used to years and years and years ago, many years ago, to help dry up the milk, but they don't do that anymore. There were some dangers to that medication, so we don't use that anymore. So all we can do is, try to keep those breasts from being stimulated, so the milk doesn't start to come in. Okay. Any questions about that? All righty. So next, we're going to look at the gastrointestinal system. So what we're going to see typically with moms, they are so hungry after they delivered. They are starved. They haven't been able to eat. Usually they're just ice chips, maybe clear liquids. But so they're just starved and they've done a lot of work. So it's, very common for these moms to be quite hungry. So we want to get them anything they want to eat for sure. And typically the husbands are great about going out and getting them whatever they want to eat. But they should get, a good diet afterwards and lots of fluids. I mean, they've lost a lot of fluids. So definitely they need to replace those fluids. We want to make sure that they have plenty of ice water. So we're always checking, encouraging them, and especially with breastfeeding, to get that milk to come in, they need to have a lot of fluids on board, and they've already lost a lot of fluids. So we need to rehydrate them a lot. So definitely provide them with a lot of fluids. And they're going to be losing it also through diuresis, which we're going to talk about in the next slide. They lose a lot of fluid because, they've had extra blood supply on board for the pregnancy, right? They have 50% more blood during pregnancy. So the body has to get rid of that extra fluid and blood, so to speak. They've lost blood, but more the fluid. I mean, blood is essentially 95% water anyway. So they have a lot of fluid to get rid of after delivery. And they're also, which is on the next slide, also they're going to be, going through diuresis, and they're going to be perspiring. Some moms wake up in the morning or in the middle of the night and they're drenched. And so we need to let moms know, that's just your body's way of getting rid of that extra fluid. Okay. So definitely they need to replace that. As far as bowel movements, it may be 2 to 3 days before they have a bowel movement. They haven't been eating during labor. And also the bowels get a little bit sluggish afterwards. So what I'm seeing in the hospital is that all moms are ordered a stool softener. That does help to soften that stool. So if they delivered vaginally, it's not uncomfortable to pass that stool. And if they have a C-section also, with that incision, can be uncomfortable to pass a stool. So we want to let them know it may be 2 or 3 days. If by the 3rd day they haven't had a bowel movement, then the doctor can recommend what they can take at home to, for constipation. Okay. And the sluggish bowel is due to the progesterone effects and the decreased muscle tone that's present after delivery. As I said, women with episiotomies, with incisions, with lacerations, with hemorrhoids that can occur, they may be a little bit fearful about that first bowel movement, fear that it may be painful, and they may, try to hold off on that. And we want to make sure that they're not going to do that, because that will just make things worse. So like I said, they are definitely what I'm seeing at Huntersville is that they're ordering stool softeners for everyone, so it shouldn't be a problem. Okay. And since that area, this helps also with urinary system are those Kegel exercises. So that's a great exercise we want to encourage all moms to do after delivery. It's kind of like that vaginal area is an elevator, and you're going up with the elevator and down with the elevator. And, Miss Beavers talks about this. Nobody knows you're doing them. So you can do them as often as you can think of it. And they help get that area strengthened, get it back to normal, get circulation going there. And it really does help that area to heal. So we definitely want our moms doing Kegel exercises. Okay. All righty. Urinary system. So normal kidney function typically returns about 6 weeks postpartum. What happens postpartumly is, as I already hit on, they don't really realize that bladder is full, okay? They have an increased bladder capacity, so they can hold more urine. The swelling, the bruising in that vaginal area can make, around the urethra, can make that sensation of a full bladder less obvious to the mother. So this can put that mom at risk for having an over-distended bladder, which, as you see on this picture, pushes up that uterus and, can cause that uterus not to contract well. So we want to make sure that we remind our moms to get up and go every 2 to 4 hours, right? There's a risk for bleeding. Also, if that urine is just sitting in that bladder, there's also, stasis of urine. It could put them at risk for urinary tract infection. So another reason that we definitely want to make sure our moms are getting up and going to the bathroom every 2 hours. Okay. All right. So we see that diuresis kick in where they were losing all those fluids, which causes that bladder to fill very rapidly. So, once diuresis kicks in, which is usually about 12 to 24 hours after they deliver, the kidneys, are trying to get rid of all that extra fluid. It can be from 2,000 to 3,000 milliliters of the extracellular fluid because of that increased blood supply during pregnancy. So the body's, getting rid of it. It doesn't need all that blood anymore. So definitely that bladder's filling up quickly. And, we want to let our moms know they're going to be sweating, they're going to be urinating more, and it's normal to get rid of all that fluids and the swelling. If they've had any swelling in their ankles, helps to get rid of all that. Okay. So our cardiovascular system. So blood loss in the first 24 hours accounts for about half of the red blood cells volume that was gained during the pregnancy. So of course, with delivery we'll talk about the amounts. Like 200 to 500 milliliters for a vaginal delivery, up to 500 milliliters is normal. And that's a lot of blood, but that's normal. And the body, has extra blood on board just for that. Our C-section moms can lose up to 1,000 milliliters in a C-section, and they still do all right because of the extra blood volume. So cardiac output initially is elevated because of all that extracellular fluid that the body is trying to get rid of. So initially the cardiac output is elevated, and then it declines by about 30% in the first 2 weeks and reaches normal levels at about 6 to 12 weeks. When we look at vital signs, the blood pressure usually stays pretty stable. could be altered depending on the mother's condition. Typically, mom's blood pressure should be, typically is what we see is it's on the lower side, and it's just because of all that extra blood volume, and eventually it will rise a little bit. But moms also can have some problems with what we call orthostatic hypotension, and I know you've heard of that, where if a mom stands up, their blood pressure drops and they get dizzy. And this can be for the first 48 hours due to the abdominal engorgement. There's a lot of engorgement in that area postpartumly. And so we want to warn our moms, we want to help them up for the first couple times to the bathroom. First all, we want to make sure that their epidural has wore off, that they can feel their, feet, they have good feeling. And then we want to get them on the side of the bed. We want to dangle them and help them to the bathroom a couple times. We also want to make sure that they're being able to empty their bladder without a problem. So we're going to measure that also, especially our moms with C-sections. Typically, they get the moms up at 12 hours after the C-section, get them up, take that catheter out, and then we want to make sure that they're able to void without a problem and emptying their bladder okay. Because of course, that's always a risk when someone has a Foley catheter, is that they don't have residual urine in their bladder after the Foley catheter comes out. And so we want to make sure that by 6 hours they have voided after their Foley catheter comes out. But warn them about that, be alert for that. Also, it's normal for these moms to have a lower pulse, okay? Bradycardia. It's not super alarmingly low, but don't be surprised if it's 50 to 70 beats per minute. Is very common in the first 6 to 10 days. And this could be that, because of the decrease once the diuresis occurs and there's a decreased blood volume from, the blood loss during the delivery and lochia, although a lochia doesn't account for a lot, should not account for a lot, the pulse slows down. There's not as much cardiac output to get through the body, get blood through the body. So when we look at pulse, we're going to see that lower range. What I want to say about the pulse is if we do see a pulse of 100, that should be alarming to us because it could indicate hypovolemia. It could indicate that they've actually lost too much blood. It could indicate an infection or a fever. Of course, we're checking their temperatures also. Initially, temperature is going to be a little bit elevated and is not concerning due to the loss of fluids. They're in a little dehydration, maybe just tad. So it's not unusual for the body. The temperature rises to help fight, trauma, and the mom has definitely, delivering a baby is trauma on the body. So it's not unusual for the first 24 hours to have a low grade temperature. After that, it should be normal. Okay. But if they are having a temperature after the first 24 hours, it could indicate infection. A little side note, on the third day when their milk comes in, they can also run a little temperature. So we're not concerned about a temperature when the milk comes in also. But other than that, temperature is an indicator of infection in these moms, and an increased pulse, okay? Or increased pulse could be pain. We all know that. So we want to make sure mom's, not in more pain than she can handle. It's going to be a little bit uncomfortable, but what the hospitals are giving around the clock is ibuprofen. And they have found that giving moms postpartum ibuprofen, even our C-section moms, do really well on 800 milligrams of ibuprofen every 8 hours, scheduled around the clock. Okay. So that's given every 8 hours. Ibuprofen is a wonderful medication for cramping, helps with the cramping, helps with the bleeding. It actually slows down the bleeding. So even girls that, women who are still menstruating, ibuprofen is a good go-to for menstrual cramping and bleeding also. Little side note, but that's what they're doing in the hospital. Of course, for our C-section, they're also getting narcotics if they need those. And we'll talk more about that later. So that's a little side note. Okay. Okay. That's about the vitals. Okay. So some other concerns or findings, normal findings are some of the lab values. So what's interesting is the white count can be elevated, and that's normal. And if you think about it, again, that mom's gone through pretty traumatic situation with their body delivering a baby. And so the white blood cell counts are normally elevated postpartumly. So we don't look at the white blood cell count to indicate that a mom has an infection, okay? What we look at is that increased pulse, right? And her increased temperature, because the white count can be as high as 25 to 30,000. And as we all know, 5 to 10,000 is normal. So normally in a person that is not postpartum, we would think, oh golly, they have an infection going on. So we can't really look at that white blood cell count actually in mom or in the baby. They're both elevated. We'll talk more about baby later, little side note. And it returns in about the first week, but still maybe a little elevated. So typically if we're concerned about a infection, we're going to look at temperature again and their pulse. The H&H is also affected. Of course, there's blood loss, during delivery, and the blood volume is decreasing. With the diuresis, the extracellular fluid has come into the circulatory system, and has diluted the blood. So typically they're going to have a lower hemoglobin and hematocrit. So we don't really get concerned about low hemoglobin and hematocrits also that we normally would on a patient that hadn't, delivered a baby postpartum. So you're going to see some pretty low ones, and that it's not a concern. A lot of moms are put on iron supplement by the doctor just to kind of help with that. Or if the doctor's concerned, they'll be put on ferrous sulfate for that to help with that. But it's not unusual to see that. I have seen, as low as 6, so they're not quick to treat these moms with blood transfusions because they're young, healthy, and their body will be able to compensate for that. When we would treat that with a blood transfusion, if we had a mom that every time she stood up, she got dizzy, she was symptomatic, okay? Her body, it's affecting her to the point that we need to give her a blood transfusion. So that's a little bit about the H&H, hemoglobin and hematocrit. Okay. Platelets also are decreased due to the separation of the placenta and bleeding. And they gradually increase by about the 3rd or 4th day. So moms initially will lose 10 to 12 pounds with the delivery, okay? So this is with the baby, including the baby, placenta, and amniotic fluid, 10 to 12 pounds, okay? So initially, moms are gonna lose 10 to 12 pounds, which can discourage moms a little bit, but after the diuresis, they'll lose 5 more pounds, but initially 10 to 12, okay? By 6 to 12 weeks, many women return to their pre-pregnancy weight. If their weight gain was 25 to 30 pounds, okay? That's why we kind of watch that weight gain during pregnancy, so moms don't have as much to lose after the baby's delivered, because as you see, they don't lose a lot with delivering the baby. as they would think. So that's why we want to keep that weight gain, about 25 to 30 pounds in most women. This is our average size woman. Of course, it's going to be less in a obese patient or overweight patient, and it's going to be more in our younger teenage moms and our underweight moms. But typical average mom is going to gain about 25 to 30 pounds. Chills that are seen right after delivery can be alarming to the moms. You'll just see them shaking. So it's just an intense shivering that they may not even feel cold, but we do give them a warm blanket. And this is normal. We need to, what's the word I'm looking for? Not encourage them, but, just reinforce the fact that it's normal. And we're not sure why this happens, but we see it quite frequently. Theories are that it could be because of the sudden release of pressure on the pelvic nerves, or a response to the fetus to mother transfusion that occurs at delivery, or because of the placenta separation. Could be another thought is it's the mom's adrenaline produced during labor and delivery, a reaction to that, or a reaction to the epidural. So these are all thoughts and theories. If the mom is not having a fever, it's not a concern. Of course, we're checking vitals every 15 minutes for the first hour, and we're doing the fundal checks and all that. We're doing a good assessment. But without a fever, it's that normal process that occurs, and we just have to reinforce that it's a normal process that the body goes through, and get them a warm blanket and reassure them. A little bit about the diuresis. Diaphoresis occurs with the diuresis, as I said, typically at night. And it's to, get rid of the excess fluid and waste products. So warn moms that they can have that happen or will have that happen. And typically it is at night. Okay, well, I will finish this slide and then it's about that time. After pains. So what we see in our primips or primiparas, our first-time moms, they do have the after pains, but it is definitely worse in our multiparas, our multips. These are moms that have had at least one other baby. And the more babies moms have, the more after pains they have, because that uterus has been stretched out, several times. So it's, that muscle gets stretched and it has to work a lot harder to get back down to the size it needs to get. So some of these moms are quite uncomfortable with their after pains. So we need to reassure them. We need to make sure they're getting their ibuprofen every 8 hours, and, just be aware that they may even need something stronger if they're like having had their fourth baby, because the after pains can be quite uncomfortable. It's just that contractions of the uterus, trying to get down, clamp down on that placental area. Also, if moms say, gosh, it's not bad, the cramps aren't bad until I breastfeed. What are we going to tell moms? That's normal, because there's an endogenous oxytocin, and we might not want to use those big words with moms, but there's a normal process in the body that releases the same medication that we've given you if we've induced your labor or gave you after you delivered. It's endogenous oxytocin, and it's the body, doing its natural thing. And breastfeeding is, of course, the natural thing. And with breastfeeding, it helps clamp down that uterus. So if we have a mom actually that's having, a little problem with a boggy uterus, that can be one, we'll massage, but that can also be one of the interventions that we would encourage mom to go ahead and breastfeed, because that can clamp down that uterus. So it's nature's way of taking care of that important task of clamping down on that placental site, that uterus clamping down on that placental site. If they have a big problem, we may have to have them take a medication about an hour before they nurse. And I know some moms are leery about taking medications, especially narcotics, but if they're that uncomfortable, they really need them. I'm an advocate of, you need to be comfortable. We want you to breastfeed. And you just have to, know and teach mom that there's very little of that goes through to the breast milk. If we can time it so it's not that close to breastfeeding, but if she's uncomfortable, we need to reassure her that it's okay for her to get something for pain, that there's very little that goes through to the breast milk and it will not hurt the baby. Okay. All righty. Well, we'll stop there and we'll pick up on slide 11. What questions do you guys have for me? Anybody have any questions? I know you wore slap out after your test. Okay, well, let me know. Let me see, I have some chats. And I do not see those when I am doing the lecture. Oh, you have a different pharmacology book? That's okay. You can look up the medications that were on the medication list for you to have completed for your OB clinical rotation. Just look those up in your med book, in your drug book, okay? You don't have that pharmacology book, that's fine. It will give you the same information. I did not realize you guys had a new one. Okay, so I will post this on Blackboard. Great, okay. Any other questions you can send through the chat real quick or just yell them out?
How many PowerPoints do we have?
Okay, quite a few. I will have to look. I would have to look to tell you.
Okay, I was just wondering. I didn't know if it was just this one. I didn't think it was. I just wanted to, yeah, I just wanted to make sure.
Yeah, you might not have been on when I was talking about this, but yeah, I'm going through. I love to just go through and just make sure there's nothing I want to change. I did not teach this portion last spring, so I'm just refreshing myself and making sure my notes look good before I put them up. Okay.
Perfect.
Yeah, I want to say there's about 5. I'm they're not all the same length, but
Okay.
I'm working on those and I will get those up for you. Okay.
All right. Perfect. Thank you.
All right. You're very welcome. All right. I look forward to seeing you guys. One more week of clinical, and then I will see you guys on Monday for lecture. And let me know if you have any questions along the way.
Thank you. Bye.
You're welcome. Bye-bye.